Hey, everybody, let's talk about psychodynamic therapy a little bit. So, what is psychotherapy? Well, Summers and Barber said that it's a personal exchange between two people that has a beginning, middle, and end. And so the patient and therapist come together, we form a connection, experience a memory, we have some emotion, and then we wind down and separate. And hopefully the patient is feeling better and the therapist wiser. So this is a relationship, like some romantic relationships, beginning, middle, end, some family relationships. So the relationship with the therapist and the patient is very similar in that it often has a beginning, middle, and end. I'll note here that in this vein of psychotherapy, the patient term is used. In my therapy practice, I say client. I think patient is kind of medicalizing and pathologizing, but whatever, just pointing that out. So, what's psychodynamic therapy? Well, it's exploratory, it's supportive, it's very interpretive. So the therapist is really listening for what the patient says and trying to interpret this in the context of their relationships, their history, their dreams, their fantasies, and so on. Um, in this mode of therapy, we take a lot of look at the past patterns, the past experiences. And we're very much aware of the therapeutic alliance between ourselves and the patient. Um, so that relationship really drives the depth of self-exploration that the patient does. So in this form of psychotherapy, transference and countertransference is very, very important. It's unique to this kind of therapy. There are lots of different interventions, and it values the personal narrative as the core to growth and change in therapy. So there's a couple of different types of models of psychodynamic psychotherapy. So the classical psychodynamic psychotherapy was born out of psychoanalytic theory or therapy from Freud and his contemporaries. And so that was very open-ended. It was pretty vague. It was not well integrated with other modalities. It's less interactive, and it was less focused and goal-oriented. The new pragmatic psychodynamic model still talks about developmental and conflict-driven concepts. But there is a diagnosis, there's a focus on education, there's a focus on transparency with the therapist and the patient. And it's really actively integrating other treatment modalities. We'll talk about that in a minute. So the therapist is very much actively engaged in this therapeutic model. Remember, in psychoanalysis and classical psychodynamic therapy, the therapist was asked very open-ended questions and really just sort of sat there while the patient talked. Not so much in the new um, in this pragmatic psychodynamic psychotherapy. So in this model, we're still looking at intrapsychic conflict. We're looking at our internal experiences. So our fears, our wishes, our rationalization, um, some of the prohibitions that we grew up with, maybe. We're some therapists call that our shadow side. So we're looking at those things that we don't quite talk about much. They may be unconscious and they're stirred by our drives. And so when you look at the drives of a child, um, you're looking at attachment, you're looking at that bonding, you're looking at mastery and really affiliation. So if you look at, a young child, a baby, they're trying to attach. Um, Toddlers are trying to attach, they're trying to bond. As the kid gets older, they're trying to master things. And then as they move into older childhood, certainly teenage years, the affiliation is very important to them. So that's a drive that we have. We all have fantasies, we all have wishes, we all are stirred by those things. Um, and we all think about those things. So we think about ourselves in the context of the world. And so we have feelings, we look at our conscious experience of emotions. These are all things that we talk with our patients about in therapy and that we recognize in ourselves as well. So how do people change in therapy? Well, insight and self-awareness, super important. And we help them do this by experiencing painful thoughts or feelings or emotions, memories. I have a young woman that I'm working with who had a fair amount of childhood sexual abuse, and so it's very painful for her to think about those things and to experience those. And so in my practice, I'm helping her do that in a safe way and at her own speed. I've worked with her about a year and a half now, and she's just now getting to the point where she is able to kind of talk openly about it. She's journaling some about it, but she was very stuck there for a long time. Part of her relationship with me is that I try to be an empathetic therapist and an empathetic male therapist who cares about her and who is able to try to help her. In our work, I balance healthy boundaries with her. She's tried to text me a few times about wanting to talk about things by text in between our sessions. I don't do that, and in a kind way, I kind of say, I'm not able to do that, and she understands that. Cultivating that newer perspective for her that all men are not out to hurt her or harm her is important in our work. And then really helping her with some new responses as well. Um, so if you think about transference, and I'll stick with this young woman who I'm working with. When she first came to see me, she had this perspective of men harming her because several men had harmed her. Um, she had the perspective of me in the present reality and the relationship that she's developed with me over the last year and a half. So at first she was super anxious about our time together. And even in our last session, she said, this wasn't about me, but was about another male that she worked with. And she works at a hospital and she found herself in a room alone, a small room alone with a man. Uh, and it was a supervisor. They were talking about things, but she felt very trapped in that situation. And so she left the room very suddenly, and he was wondering what was going on, but it was really a trauma response that she was having. So when she told me that, I spent some time talking with her about my office here, making sure that she felt safe. Sometimes she and I, after like an EMDR session, we will go out and take a walk. She likes to walk around just the block where my office is, and that's very calming to her. And we just walk, and sometimes we talk, but often we don't say anything. So all of that transference and countertransference that I'm having toward her is developed through that relationship. So when we're looking at that therapeutic alliance, we're looking at the alignment of the purpose between the therapist and the patient. We're looking at the tasks. So her task is to come to sessions, to express her thoughts and feelings, observe them, try to understand my feedback. Um, and then my task in meeting with her is to very much try to understand her, to be focused, to help her conceptualize what her problems are, and to really understand her perception. And then again, that bond is an attachment between us. She trusts me, and I've worked hard to gain her trust over the last year and a half by caring about her, by showing her that I care, but also being objective and not being afraid to give her honest feedback in the session. So yeah, there's that. So when we look at the dimensions of that relationship, there's the therapeutic alliance, there's that real relationship, and there's transference that's going on. So I definitely care about her. I'm trying to help her, but I will never be friends with her. We'll never have um, a relationship outside of my office, and that's intentional. That's purposeful. I'm trying to use that transference that she has with me to help her, but I'm doing it in a controlled way. Um, and then finally, looking at this kind of grid here about facilitating the alliance between us. Explaining therapy, being curious, being warm and enthusiastic. Again, remember, psychoanalysis used to be very, the therapist actually sat behind the client or the patient, and they laid on a couch, and you sat behind them and just talked. There was not this warmth um, in the relationship. And so, looking at strengths, so that's a very social work kind of thing, honing in on the best qualities of the patient, um, thinking about how you feel, understanding that countertransference or the enactment. They talk a lot about enactment, and that can be a thing where, again, if my client hated men, which who wouldn't? I mean, most men have hurt her. She could enact that toward me if I set a boundary with her and said, I disagree with you about this or whatever. She could feel that enactment toward me. Um, so again, understanding, clarifying goals, um, rolling with resistance. If that's, you might remember that from motivational interviewing, if you've studied that. And then, attend to if you're feeling if the patient's feeling too good or too anxious, this may indicate some enactment on their part. And then looking at times when the alliance is ruptured. And for example, if this client got mad at me for some reason, um, that wouldn't feel great on my end, but it would also make me kind of curious about why that happened. So above all of this, see the best in your patient, but also help them be accountable in their own world. So you're encouraging them, you're caring about them, but you're also helping them uh, be separate from you and be separate from that relationship.